Now, to finish this chapter, we have a little table showing you maybe better choices in situations of comorbid condition. Comorbid condition simply meaning here a patient having both hypertension and the actual disease shown in the left column. So if someone had diabetes or heart failure, we just saw ACE inhibitors, ARBs, are going to be some of the better drugs to use. By the way, for the diabetic nephropathy, I forgot to explain to you, ACE inhibitors and ARBs are good because of improving the blood supply to the kidney of a diabetic. Remember that the highly arteriolosclerosis ends up causing some segments of glomeruli to become sclerotic until eventually a nodular or a diffuse sclerosis would ensue. You know, the nodular sclerosis, the one that Kimmel, Steele, and Wilson wanted to be named after. Well, improving blood supply will decrease the actual risk of developing glomerulosclerosis in a diabetic. So always remember, with diabetes and heart failure, when you treat hypertension, these are some of the best drugs to use, ACE inhibitors and ARBs. When I'm dealing with angina or post-MI, there is no doubt that beta blockers have good proven records of improving survival, as we'll see in the chapter on angina and MI down the road. What if my patient had BPH and hypertension? Then certainly an alpha blocker would be the drug of choice, improving the symptoms and fighting the blood pressure at the same time. Finally, for hyperlipidemias, I think what we should really say, but it wouldn't fit in this table, is what is not so good to use. And remember for that matter that beta blockers and also thiazides, as we'll see in the diuretics, tend to increase blood lipids. That increase in blood lipids would never help someone with hypercholesterolemia, for instance. On the other hand, drugs like alpha blockers have an actual good effect on lipid profile, improving HDL and lowering LDL. So really anything but beta blockers and thiazides when it comes to hyperlipidemia.